Hello, this is Dr. Oviedo. Today we are going to review cardiomyopathy, myocarditis, and pericarditis. First, I want to make some general comments. Cardiac myocytes are constantly contracting and relaxing. There are numerous components involved in this: myocytes, intercalated discs, desmosomes, and gap junctions. Defects in the components involved in contracting and relaxing can result in cardiomyopathy. Remodeling of the heart in response to various types of insults can lead to dilated cardiomyopathy or hypertrophic cardiomyopathy. These are the two major types of cardiomyopathy. Cardiomyopathy generally means a primary defect of the heart. It usually implies actual heart muscle function defect, as opposed to a secondary defect such as ischemia or a valvular defect. Dilated cardiomyopathy is characterized by progressive left ventricular chamber dilatation and systolic dysfunction. It can sometimes also affect the right heart. The morphology is generally similar in the different underlying causes. Various etiologies include genetic dilated cardiomyopathy, myocarditis, alcoholic cardiomyopathy, doxorubicin cardiomyopathy, peripartum cardiomyopathy, iron overload cardiomyopathy, and catecholamine cardiotoxicity. Alcoholic, doxorubicin, and peripartum cardiomyopathy likely occur in patients with Titin mutations. We'll discuss Titin mutations later in the lecture. Dilated cardiomyopathy can have an onset at any age. It can present with heart failure, cardiac arrhythmia, and sudden death. Let's take a look at the pathology. Here is our heart with dilated cardiomyopathy. Here is a normal heart for comparison. First, let's look at normal structures to orient ourselves. This is the right atrium. This is the right atrioventricular valve. This is the right ventricle. This is the left atrium. This is the left atrioventricular valve. And this is the left ventricle. You can see the left ventricle is dilated and has an abnormal globular shape. Here I've outlined the shape of the left ventricle on the normal heart so you can compare the abnormal dilated cardiomyopathy on the left to the normal heart on the right. Please note that clinically, dilated cardiomyopathy is characterized by measurements of the ventricles. However, in pathology, we will generally be looking at the appearances of the ventricle because the measurements can sometimes be more difficult to interpret in these types of specimens. Let's discuss genetic dilated cardiomyopathy. There is a heterogeneous genetic basis. It is usually autosomal dominant, but there are also autosomal recessive and X-linked inheritance. Titin is the most common genetic cause of dilated cardiomyopathy. You can also have mutations in cytoskeletal proteins, sarcolemma, nuclear envelope, dystrophin, and mitochondrial defects. These gene defects will result in abnormal function. Impaired contractility will result in increased ventricular chamber volume. Let's discuss Titin in a little more detail. This is a drawing of the sarcomere. This is a reminder that the sarcomere contains actin, myosin, and titin. Titin provides passive force and modulates active contractile force. There are numerous truncating mutations in titin associated with dilated cardiomyopathy. I put the drawing here just to remind you that titin is a component of the cardiac sarcomere. Myocarditis can be one of the underlying etiologies of dilated cardiomyopathy. This is most commonly a viral myocarditis. It's usually sporadic. The organisms are covered in a separate lecture. In the Latin American population, Chagas disease can cause dilated cardiomyopathy. Let's take a closer look at myocarditis. The organisms are covered in a separate lecture. This is a full thickness section of left ventricle. This is the endocardium, this is the myocardium, and this is the epicardium. Here at higher power, you can see there are numerous lymphocytes and neutrophils infiltrating the myocardium. This is the appearance of myocarditis. Let's go on to hypertrophic cardiomyopathy. The clinical presentation includes sudden death in young athletes, exertional dyspnea, and it has a variable natural history. You generally get a massive myocardial hypertrophy with asymmetric septal hypertrophy, abnormal diastolic filling, and intermittent vascular outflow obstruction. Let's take a look at the pathology. Here is our heart with hypertrophic cardiomyopathy. Here is a normal heart for comparison. Let's look at normal structures to orient ourselves. Here is the right atrium. Here is the right atrioventricular valve. Here is the right ventricle. Here is the left atrium. Here is the left atrioventricular valve. And here is massive hypertrophy of the left ventricular myocardium with asymmetric septal hypertrophy. You can see the left ventricular chamber is narrowed. I put a drawing here around the massive hypertrophy of the left ventricle wall in yellow along with the chamber in red. You can see that the septal hypertrophy in this region causes outflow obstruction. Let's take a look at the histology. Here is a high power demonstrating enlarged nuclei, thick myocytes, and disorganized branching. I have a photograph of the normal heart here on the right for comparison. Hypertrophic cardiomyopathy can result from mutations in sarcomeric proteins. Beta-myosin heavy chain gene is the most common mutation that causes hypertrophic cardiomyopathy. Other genes include cardiac troponin T, alpha-tropomyosin, and myosin-binding protein C. This is autosomal dominant. The mutation in the sarcomeric genes results in altered function. The myocytes respond by increasing in size, which we call hypertrophy, and you can also get fibrosis. The abnormal function will cause enhanced contractility with impaired relaxation. You will get hypertrophy and decreased chamber volume. Let's go on to arrhythmogenic right ventricular cardiomyopathy. The clinical presentation includes palpitations, syncope, arrhythmias, and sudden death in young adults and childhood. Let's take a look at the pathology. Here is a photograph of a cross-section of the heart. Here is the left ventricle, and here is a large right ventricular chamber. You can see the right ventricle myocardium is largely replaced by adipose. Please note that adult hearts generally do have some adipose around the right ventricle. However, there will be normal myocardium underneath the adipose in a normal heart. Let's discuss the pathogenesis. Mutations in cardiac desmosomal genes are common and affect cell-cell adhesion. Please note there are numerous components to the desmosomes and there are numerous different genes that can cause arrhythmogenic right ventricular cardiomyopathy. Mutations lead to desmosomal dysfunction, which leads to myocyte death and fatty replacement. This is autosomal dominant with variable penetrance and is genetically heterogeneous. Let's go on to restrictive cardiomyopathy. With restrictive cardiomyopathy, there is decreased ventricular compliance. This will result in impaired diastolic ventricular filling. There are multiple etiologies including radiation fibrosis, amyloidosis, sarcoidosis, metastatic tumor, endomyocardial fibrosis, low-floor endomyocarditis, and endocardial fibroelastosis. Let's take a look at a gross picture with amyloid deposition. Here is our photograph. You can see these yellow-beige lesions represent amyloid deposition in the left ventricle. You can see it here, 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 and here. Let's take a look at endocardial fibroelastosis. Here is our photograph. This ventricle has been cut open and the free wall has been reflected open. You can see the endocardium has this very abnormal white appearance. Let's discuss pericardial disease. Pericarditis means inflammation in the pericardium or pericardial space. Fibrinous pericarditis is characterized by a fibrinous exudate. Serofibrinous pericarditis is characterized by a serous and fibrinous exudate and will have more fluid than fibrinous exudate. Hemorrhagic pericarditis will have fibrin and blood. The underlying etiologies include infection, inflammation, tumor, and uremia. Clinical presentations include cardiac tamponade, pain, fever, congestive heart failure, and a loud pericardial friction rub on auscultation. Let's take a look at the pathology. Here is a picture of fibrinous pericarditis. This is the heart. This is the parietal pericardium, which has been reflected away from the heart. These are fibrinous strands in between the heart and the parietal pericardium in the pericardial space. Let's take a look at hemorrhagic pericarditis. Here is the heart. Here is the pericardium, which has been reflected away from the heart. This is a red hemorrhagic appearance. Here you can see fibrinous strands between the heart and parietal pericardium in the pericardial space. Okay, that's it.